Welcome, everybody. How's it going so far? Just give a thumbs up if it's good. Okay. Can you all see my presentation?
Yeah.
Okay. Okay, so I apologize up front, but I've got a 1:40 hard stop. So I'm going to try and go through this and handle questions. And if there are more questions afterwards, we can always continue and set up a time for any further questions. And whatever question you have today will probably not be relevant tomorrow because things with COVID change continuously. So first of all, I'm taking it that many of you are aware of what's going on with COVID, and you know a lot of this. If all of this is really boring and you've heard it all a million times, don't be shy to say, you know, let us just ask questions or whatever the case is. But here's a presentation, okay? So let's talk about COVID. Very interesting disease. It presented, you know, coming out of Wuhan, China. We didn't quite expect what hit us, I don't believe, at all. And it was something that we were always on, on the back foot, trying to defend off rather than being in an attacking position and being able to actually feel like we were getting anywhere with it. So, initially we had everybody presenting with, fevers and cough and headache and fatigue. And basically it was like an upper respiratory infection that people were presenting with, a little bit like a flu. Very hard for us to discern who had, COVID, who had flu. In the early stages, we were one of the few places that actually had the ability to test, but there was very limited testing. We secured testing by, contacting everybody from the east to west coast and overseas to get whatever testing we could. And we really limited it and tried to test only people that would have an impact in terms of spread of the disease. And it was really complicated. Then all of a sudden down the road, we find out that, 1 in 5 patients present with GI symptoms. So in the beginning, we didn't think any of those patients were COVID patients. We thought they had, some sort of a GI symptom, maybe a viral infection or something else going on. And we find out that, this is a serious presentation of a COVID that, 1 in 5 is serious numbers. And that made it a lot more difficult. So really, what did we come out with in the end of the day? Just about anybody can be COVID. And that's what it literally was. As we, increased our testing, we realized that just about anybody could have COVID. More severe presentations, obviously, were trouble breathing, chest pain or pressure, difficulty staying awake. But, just about anything was and continues to present as COVID. So if we have a look at COVID versus flu, symptoms very similar. Flu does not typically have the person sense loss of smell and taste, but otherwise very similar. Complications, both of them can be multi-system organ failure. More common, we're seeing it actually with COVID than with flu, but both of them can do that. Typically, we have 1 billion people worldwide who get flu every year, but we certainly don't get the number of deaths that we've seen in a COVID infection. So this is a far more challenging viral infection than the flu. Okay, what's the treatments? I'm not going to go through all the early ones, the hydroxychloroquines and the things that were all tried. So, if you look at it today, so it's this Regeneron or this Eli Lilly, Bamlam, whatever, that no one can pronounce. I don't know how they come up with these names, but they managed to get the name. That's essentially a concentrated antibody. It's not just plasma. A lot of people are getting plasma. This one is a more concentrated antibody that is in short supply, not in big supply. Hospitals are getting them on a weekly rotation. They don't know how much they're going to get. When a patient needs it, you have to find out which hospital in your area has it. You could be different in LA or in California. I'm telling you what it's like in New Jersey. And it's a challenge to get the treatment. Antiviral, we're giving something called remdesivir. It's a 5-day IV treatment. Patients need to be hospitalized. One thing that you should know before I go into the remdesivir, the Regeneron has to be given before the patient is severely ill. It's got to be given within the first few days and before the patient is severely ill, and isn't enough to be given to everyone. So you also have to choose people who are at high risk, comorbidities, age, etc., that put them at high risk, and therefore they should receive it. Remdesivir antiviral given for 5 days, as I said, in a in-hospital setting, only because it's IV. Corticosteroids are given IV in the hospital. You can give a Decadron, which is a tablet given outpatient, and it actually has a phenomenal response. In the beginning, we were of the assumption that if you gave steroids, you would kill the patient, almost, because what you would do is you'd wipe out the immune response, and therefore they would get much sicker. We actually found out by default that, when patients were just about at the end of the road of what we could give them, we started giving them corticosteroids and found that they actually responded really well. Why? Because this is an inflammatory process. It's a disease that causes an inflammatory process, mainly in your lungs, obviously, but it can be multi-system. And the corticosteroids do really well to suppress that response, that body response, and therefore it does well to limit the damage to the lungs and to other organs. Another thing that we found, we didn't know it all in the early stages, is that you have a higher potential to have clotting disorders. A lot of people presented with stroke. Actually, they tended to be milder strokes, but a lot of strokes, pulmonary embolus, other issues that were secondary to COVID, and it was caused by clotting issues, and that is easily treated with heparin in the hospital or with Eliquis, which can be given in the hospital or in the outpatient setting. None of this occurs with flu, so flu is given Tamiflu, and it's a lot easier to treat. Okay, how do we prevent this disease? Well, I mean, you can't prevent it, but prevent it from spreading. Masks, social distancing, avoiding a super spreader event such as chasanas, a wedding, a bar mitzvah, anything where everybody's there without social distancing and without wearing masks. Now, I know it's not a popular piece of advice, but it's practical. It helps. Now, let's just understand masks for a second. If I wear a mask and no one else wears a mask, it doesn't do too much of protecting, because the virus can get around the mask and into the side, unless I wear an N95 mask continuously, which is difficult, but you could do, and that would protect you to high, it's actually supposed to be to 95% protection. It's probably about 97% protection, but a regular mask doesn't. I know of a situation where there were 15 people who wore a mask during Rosh Hashanah Yom Kippur in a shul. The other members did not. Of the 15, 3 of the 15 were high-risk people. All 3 of them got COVID over the holidays, unfortunately, and that was because who needs to wear the mask is the person who has COVID. And unfortunately, with this disease, a lot of people are asymptomatic, don't know that they're a spreader. They're not doing it on purpose. They have no idea that they're a spreader. They're not wearing the mask. And therefore, unless you are significantly social distance, unless everybody's wearing a mask, it really doesn't help for you to be the Lone Ranger who's wearing the mask and everybody around you doesn't. You need the person who's got the COVID to be wearing the mask. That's how you stop spread. Problem is, we don't know who they are, and they don't know who they are. Okay. Other things that have been thrown at people is zinc. Not very successful, to be honest, but still given. Nobody really knows why. If you ask any of the infectious disease doctors, they say, well, it causes no harm, so we give it. We don't think it helps. Vitamin C, the same. They tend to give it. Doesn't really help. Vitamin D, incredibly interesting. A lot of studies show that if you have appropriate levels of vitamin D in your blood, you do much better with the disease. However, you cannot give the vitamin D post-infection. You have to give the vitamin, you have to get those levels up before the infection. So it's only useful if a person has good vitamin D levels, or make sure that they maintain good vitamin D levels continuously. Okay, so next thing, let's understand what is isolation versus quarantine. If I'm going too quickly, slow me down, but I know I'm on a tight schedule of time here. So isolation means, somebody got the illness, I got the illness, and now I need to isolate. Isolate means I don't let any of my family come near me. I go into a separate room. I stay there for 10 days. If on the 10th day I am asymptomatic. I can come out on day 11. I will not infect anybody, generally speaking, and I'll tell you a little trick about that. But I need to isolate. Why I say that the little trick is the problem is that there is research, which the infectious disease docs will tell you, which indicates that if somebody got a severe infection, they can actually spread the virus for up to 28 days. However, those people are usually in the hospital for close to that amount of time. So by the time they get out, they're probably not infectious, but it happens to be a reality. What is a quarantine? A quarantine means that I was exposed to somebody who has the virus, but I don't myself have the virus. And therefore I need to be careful that I'm not incubating it, become sick, don't know about it, and pass it on to the next person. Plus, for 3 to 4 days before you get sick, while you're incubating, you're actually contagious. So that's another thing. You don't want to be spreading to other people during that time. So initially, the suggestion was to have 14 days of quarantine, as you all probably know. Actually, the science showed that after 11 and a half days, 97% of incubation occurred, meaning you would know whether the patient at that point was a spreader or not, and that would be that. It was taken down to 10 days now without any good science behind it. The explanation was because people would be more compliant, which is a very interesting CDC, Center for Disease Control explanation, but okay. And it's now the recommendation is that you can have 7 days with a negative PCR or rapid test. So on day 5 of your isolation, quarantine, you can go for a PCR or a rapid test. If it's negative, then on day 8, you have to stay in quarantine for 7 days. On day 8, you can go out. The other option is you don't need to have a test at all. You wait 10 days. After 10 days, you're free to go out. Okay. As I pull this up, I'm going to give me a half a second, and I'm going to pull it up because I did for me. Let me look up for you guys. Half a second, I will be there. Okay, so if we look for California, okay, this is looking at New Jersey, our daily new cases, and this was taken about 2 or 3 days ago, so I do apologize. It's not up to date, although the California one I'm going to give you is up to date. New Jersey is running at 48.4 cases per 100,000. California is, and this is totally up to date, is running at 99.7 cases per 100,000. So your numbers, out there are not encouraging. And I will give you an update at New Jersey. Let's just see. It's running right now actually less. It's running at 45.4. So our numbers have gone down, which is nice. Let's go into the next slide. You can actually go into this website and look at this data yourselves. It breaks it down by counties, for example, and I'll just give you Ocean County updated, which is where we live in Lakewood. It's now at 54.1. So, the numbers are much lower than by you guys. And then if you have a look here, you can see we had our first wave. Can you see my pointer? And that was over, March to May. It was when most people had that first wave. We had our second wave. Then we kind of got out of that second wave and we've gone into a terrible third wave, which is actually reaching much higher levels than we did the first time round. It is possible that that's not absolute. It's because there's more testing available now. If you have a look at this, this is looking at Ocean County, the cases in Ocean County. If you have a look at this, it's looking at hospitalizations. Hospitalizations, even though we got so many more cases, on the second round, we are so much smart. I don't think we're smarter. That's probably like not a good term to use when it comes to COVID. Our lack of knowledge is alarmingly, visible to everybody. But let's say that at least smarter than we were. How about that? And you can see we actually know we keep patients out of hospital. They do much better. So hospitalizations are down, and ICU hospitalizations are down as well. That was the worst. What we've done locally in our area is we created a tracker where we could actually track, on a weekly basis what was going on within our health center, so that it allowed us to see trends just right around, what's happening right in our area. Okay. Hold on a second, because I got everybody here blocking the slide a sec. Okay, so this is looking at what we've done, and again, it's a few days outdated. Total COVID testing that we've done is we've done over 62,000 tests on people. So we've been really one of the centers. In fact, we have done more testing in the state of New Jersey than anybody else. We've actually done testing for antibodies on 22,000 individuals. So the numbers are pretty significant. What's very interesting is if you would speak to the community in Lakewood, a lot of people would tell you, a huge number of people would tell you, no, I had it, I had COVID, I'm definitely fine, but it doesn't bear out in our antibody testing. Our antibody testing shows that only 43% of the 22,000, which is a significant number, statistically, we got the power there, only 43% are positive, 57% are negative. And I'm going to tell you something even more astounding, and this is astounding. So those who want to be involved with COVID research as we move forward with the projects, I'm telling you, there is so much interesting information when you start looking at it and breaking it down. So we had a look at, of the people who are being tested, we group them into families. When you group it into families, now think about it logically. If you've got one person who's positive in a family, you've got a higher chance of spread within that family, right? So when you take your 22,000 individuals and you look at how many households of those 22,000, how many households were positive and how many households were negative, this is astounding. You have 33% of the households being positive and 67% being negative. Now, if you took this number and you took it to the rest of the country, everybody would fall off their chairs because they would say the average positive rate in the country is 15% at high. So therefore, saying that you have 33% of families who are positive is very high in Lakewood, but nowhere near where the community thinks it is. The community thinks it's about 70, 80% of families who've had it, and it's not true. Okay, let's talk about immunity from antibodies. So, is there immunity from antibodies? I'm sure you've heard backwards, forwards, upside down, and you've read a whole lot of things. So I'm going to tell you the way I understand it, what I believe. My disclaimer is I'm not an infectious disease doctor. I did internal medicine and peds, primary care. That is my knowledge base. However, I happen to stay on top of COVID situation, and I'm in contact with a lot of infectious disease doctors from East to West Coast, and I like hearing input and I like discussing that. Vaccinologists I speak to, I really like finding out what's going on, just because I think that's the way we're going to beat this disease. Antibodies are like this. CDC does not stand behind antibodies per se. The most that the CDC was prepared to say is that after you get the infection, you are protected for 3 months. You are very unlikely to get an infection within 3 months. They don't say why, what, where. That's all they say. The reality is there's been a lot of research. Initially, they said you're protected with antibodies. This is now outside of CDC. This is academic infectious disease. Said you are protected for 3 months. The latest research now comes out and it says you're protected for 8 months. Why is that the case? Very simple. Because we have had so many million people being infected with the disease, and we've had so few reinfections. And a lot of people are no longer protected with antibody levels. If we would take antibody levels in their blood, the antibodies have waned. So what is protecting them? So we know that B and T memory cells are what's going to protect you. We also know that T memory cells is a far better indicator, which was proven in India, I believe it was, a far better indicator of protection against COVID-19. Problem is, you cannot do a T cell memory cell level in a lab in the USA, or for that matter, anywhere in the world. It is only done in research laboratories, and therefore it is not a common test to do, and very difficult to actually know what anybody's T level cells, T memory cell level is, unless you're part of an academic study. Okay, so bottom line is, now what about if you have antibodies, you're not getting the infection again, but infectious disease doctors will drive you crazy and say, but we don't know if you spread the disease. In other words, you may fight off the infection to a level where you can't become infected again, but you're able to carry the disease and pass it on to somebody else. So that sounds great, except we're not seeing it in the real world. When you look at the dynamics of what's going on out there, it doesn't seem to be the case. So it does seem to be that natural immunity from an infection is it seems to be a fairly safe, it's not absolute. There are definitely reinfections, but it seems to be a fairly safe protection for you going forward. Now, problem with this disease is it has a wide range of the ways it affects you. Younger children, most of them have innocuous disease. It's irrelevant. Adults, most people who have got it get a mild disease. Some are asymptomatic, some are very mild, some get a flu-like illness. It's the few who get the the severe disease, but that severe disease has proven to be more than lethal. It is deadly lethal, which is an oxymoron, because we're saying the same thing, but it's just, I'm saying it for emphasis. And that's problematic. So so how do we protect people? So it's all about getting to herd immunity. Herd immunity typically is at 70%. Nobody knows what herd immunity is going to be for COVID. Dr. Fauci just came out and said he thinks it's 90% or 95%. You're not getting to 90 or 95% immunity in a community. It's never happened. Well, it hasn't never happened. They did it for smallpox, but it's pretty difficult to do it. And I certainly hope that 70% is going to land up being enough, because we all want to see the end of this this infection. We know that we have a vaccine which is 95% effective. So if we can get this vaccine out, vaccinate enough people, the problem is if the younger generation doesn't get involved with getting vaccinated, and if they did not become ill and they don't have natural antibodies, we will not get to a herd immunity, and we will not protect our senior population, our at-risk population with comorbidities, because 95% of a vaccine, even though it's one of the best vaccines, flu vaccine is somewhere between 40 and 70% effective as a comparison on an annual basis. 95% is phenomenal for a vaccine. But again, that puts a person at 5% risk if they are in the high risk category. Okay, so now what about vaccines? So we have a lot of different talk about vaccines. Am I going too quickly, Rabbi Grumman? Yes, no?
I have a quick question for you, actually, Rabbi.
Yes. No, Rabbi.
No, Rabbi. Okay, sorry. I was just confused with Rabbi Grumman. So for the antibodies, let's say if someone has it, does that still mean that you're not at risk to give it to someone else if you you obtain it, or it means you can't?
Right. So I'm going to go back and say it's exactly what was being said before. The majority of infectious disease doctors will tell you it doesn't seem, from what we have seen so far, it does not seem like you're able to carry the disease to any extent, and therefore you're not a spreader. Okay. That said, there are some infectious disease doctors who are not so quick to jump onto that bandwagon. They don't say it's proven you're a spreader, because we can't prove that. But they say it's not proven that you're not a spreader, and therefore you have to be careful.
Got it. Thank you.
Okay.
Dr. Friedman?
Yes.
As a follow-up, with the reinfection rate for people who've had it, I know that there are some instances where people are infected again after they've had the virus. Is that just like a very low percentage? So is it like the majority of people aren't able to spread? So how would you explain like people developing the disease, probably getting antibodies, and then being infected again with COVID?
Okay, so it's two different, it's not the same question. So I'm going to break it down, because what you said are two totally different things. Let's first of all talk about reinfection. So reinfection does occur. Reinfection means that you have to be able to show that the person had it first time and second time. I can tell you that I was involved right in the beginning as the reinfections were being discussed. I was involved with the studies both out of Rutgers and out of Mount Sinai, which were two academic centers which were looking into different strains, or why it could be that, that you got reinfected. I can tell you that 99% of the cases that were sent to them were proven not to be reinfections. They never had it the first time. It wasn't a proven the first time. The second time they didn't have COVID. It was dead virus that they had in their nose. They had picked up a cold, and then they thought it was COVID, and it wasn't. So the first thing is the majority of cases that you are hearing of reinfection are not real. Okay. I'm telling you, when you actually look into it and break it down, didn't happen. That said, there are documented cases of reinfections throughout the world, small numbers, not relevant. That means you getting sick again. It doesn't mean your ability to spread it. Now, if you get sick again, for sure, you're going to have the ability to spread it to somebody else. But it doesn't mean that there are a whole lot of other people running around the world who aren't getting sick again, but are carrying the virus to a level where they can spread it to others. Okay? Okay.
Sorry, follow up on that question.
Sure.
Sorry. Is the reinfection after the 3-month like antibody period, or is it just like a month or like a few weeks after they just had the COVID, like those small amount of patients that did get it?
Right. So my understanding is that there are about 2, something like that, people who were actually shown to get reinfected within 3 months, but almost no one. That's out of the entire world. Those who have been reinfected have been after 3 months, and that's why the CDC felt confident to come out with the 3-month recommendation. Now, what I can tell you is that just from our data, we'll tell you that about 25% of people who get infected do not develop natural antibodies. And most of the people who I tracked, and I didn't track everybody around the world. I only did things locally in our area. Of the people that I tracked personally who were reinfected, I did not track a single person who had antibodies and was reinfected. All of them who were reinfected were people who did have a first and second infection, didn't have antibodies. We tested them after the first infection. They never developed antibodies, and they never developed them later. Why does that happen? We don't know. We suspect it's genetic. There's a lot of talk about, O blood type, definitely we are finding that O blood type tends to have a lower potential to get infected, but it's certainly not protective. O blood type is not protective. There's no one who's immune totally from this disease. And we think it's more genetic. And, the question is now, we think that of this 25%, there's going to be an element who are protected anyway, because they have a genetic potential not to develop the antibody, but be protected. And then there's going to be a subclass of that who don't develop the antibody, and they are at risk of getting reinfected. And we think that that's the smaller percentage that we're seeing. Very in the air. Nothing, there's a lot of research going on now into genetics and COVID, but it's got many years to go before we know the outcome.
So can I ask a quick follow-up based on what you said? So yeah, I was gonna actually ask, so in the previous slide, it was mentioned that these B cell and B and T memory cells can only be produced if someone tested positive for the antibody, right? So I guess like there's no way for anyone to have any sort of natural genetic immunity, because if someone tests negative for the antibody, which means they've never had it and they were heavily exposed multiple times and they just didn't get it. You're saying the explanation for that is just genetic and luck, or like, what would you say?
That is what the geneticists and the infectious disease doctors, that's their hypothesis, not proven today, because although there's a lot of research going on with this, it's going to be years down the road before they can tie enough data to the genetics to make sense of it.
Okay, thank you.
Okay, let's go in a little bit and then it will take again some questions. Okay, so vaccine. I'm going to make this quick. I'm sure you've read fortunes about the vaccine. So you've got your, I'm sure you've got your double strand, DNA, your single strand RNA. This is a messenger RNA, a short strand of RNA, which is being sent into a cell to create a spike protein, and then the body creates a natural antibody against that spike protein and protects you. You cannot get sick from the messenger RNA in terms of COVID. It is not COVID per se. It is not a live attenuated vaccine. It is not a dead killed vaccine. It has no COVID in it. It cannot give you COVID in any way whatsoever. You can get side effects, which we'll discuss. You cannot feel well. You're not getting COVID. It is research which has been around for about 20, 30 years. It's considered to be the future vaccines, and it has been for many years. Why did it never get anywhere? There was never money put behind it. Nobody actually put the dollars that were needed to get this to fruition in terms of creating vaccines. The whole future vaccines may change based on this, because with the billions and trillions or certainly billions of dollars that were given to the companies to be able to, get a vaccine out quickly. They didn't start in the beginning. They took from where they were in the messenger RNA concept of vaccines, and they continued their work, now being well-funded, being able to get a lot of people working on the program, and they were able to finish the development. Okay, good things, bad things. So now you've got this messenger RNA, probably the most advanced form of a vaccine. As I say, good chance a lot of other vaccines will go into that same direction. Proof, 95% effective. That is phenomenal. The AstraZeneca is not proving to be, they're talking about 70% effective, which is more typical for a vaccine, and that's not using the mRNA. Problem with the mRNA is ramping up to, in development, in production, sorry. It's a complex delivery system. In order to be delivered into the cell, it has to go through nanoproteins. And that's with Pfizer, very complex in how they created that. Moderna were able to make something a little bit of an easier process, but very difficult to ramp up. And I've got another slide. But there are DNA proteins that are in development and viral vectors. They're using adenovirus is the main one that they're using as a viral vector, protein subunits, and et cetera, et cetera. Okay, I've got to make you all smaller here so I can see this. 1 second. Okay, so 1 sec, whoops. Okay, so this is looking at the Pfizer and the Moderna vaccine and the AstraZeneca. Okay, so basically, if we have a look at it, again, a 95 and 94% effective versus a 70% effective, and that's the difference between an mRNA. But then the difference is they can create 3 billion doses, and these are much slower to produce. So, if you look at it in terms of getting a vaccine out and controlling this, this pandemic, even if you're 70% effective, but you can get the vaccine out quicker and it's a safe vaccine, it may be more effective than something that is, has much better protection, but it's going to take an additional, probably 1.5 years to be able to reach the numbers that AstraZeneca can reach. They're all 2 doses, slightly different. Pfizer's 3 weeks apart, Moderna's 4 weeks apart. Whoops. The main side effects are pain at the site of the injection. Like any vaccine, you can get fever, headache, chills, etc. Again, you're not getting COVID. You're getting, typically a reaction to the actual vaccine. Pfizer 16 years and above, Moderna is 18 years and above. And then, the whole question on pregnancy nursing, there was no research done on it. The ACOG, American Academy of OBGYNs, came out and said it's fine, it's safe. People do believe it's safe based on the science and understanding of how the vaccine works. However, it has not been proven. They have been tasked now by the government, both Pfizer and Moderna, that they have to do studies with nursing and pregnant women so that they can definitely define that it's safe. Okay, this is just, the non-injectable vaccines that are in development. There are pages and pages of vaccine development still going on. I'm not going to go through all of them. Okay, let's see if there's anything here. Pfizer, very complicated. Once it's, you got to freeze it at minus 70 degrees Celsius. Minus 70 degrees Celsius, that is very, very cold. And once it's been thawed out, it's stable. You can refrigerate it only for 5 days. It is stable for 2 hours. Very complex, and it has to be reconstituted. Very complex to put together. I'm going to tell you, I'll tell you now quickly. There are 2 so-called side effects that I think we should be on the lookout for. The one is this anaphylactic reaction, which seems to, it seems to be to the PEG, which is in both the Pfizer and the Moderna vaccine. The reality is the only people who seem to have a severe anaphylactic reaction were people who had a history of anaphylactic reactions in the past. Other people do not. So it does seem like it's controlled and it's fine. Bell's palsy, that's a facial nerve palsy of your facial nerve, which comes here. Your lip will tend to droop. You won't be able to speak properly, etc., etc. Treated very well by early intervention with corticosteroids. actually get excellent results. If it's left and you don't treat it early, then it's a disaster, and it can actually have long-term sequelae. So definitely not recommended. Now, Bell's palsy exists in the general population. When you have a look at how many people were given the Pfizer vaccine, and when you look at how many people developed Bell's palsy, it equated to a normal incidence within a population. However, all 4 of them were from the people who received the vaccine and none from the placebo. So, it's within the normal range, but, one has to think about that. With Moderna, we had the same 4 people also fell with, I'm talking about the Bell's palsy, also fell within the range. 3 of them were the vaccine group and 1 was placebo. Spoken to a lot of infectious disease and other research people about it. They all feel that right now, that because it statistically falls within the expected range, we should not feel that just because it was a higher incidence within the vaccinated, that it's a concern. In my personal opinion, it needs to be monitored carefully going forward, because the fact that 7 are vaccinated people and 1 not is some area for concern. Again, the most important thing is diagnose it early if it does happen and treat it with steroids. The person will do fine in most cases. What causes Bell's palsy in the general population? Lyme disease can cause it. Herpes viral infection can cause it. So it is something that does occur within a natural incidence out there. Anaphylaxis, if it occurs, you obviously have to treat it straight away. Should immunocompromised patients get the vaccine? So, this is a question which really is on a one-to-one, should be, in my opinion, discussed with the provider. The bottom line is that the general consensus of CDC is that they should. It's not a live vaccine and it's probably safe, but it probably deserves a discussion. Remember that if you're immunocompromised, you will also mount less of an antibody response, and you probably will not be protected to the 95% level because you're not able to produce the same level of antibodies. What about pregnant women? So, as I said, the advice given now by ACOG is go ahead and get vaccinated. However, it wouldn't be, it would be a smart thing to say, why don't you just wait until the data is, take a little bit of time, but until they actually publish data and they finish doing their research on it. What about the new strain that's come out? So there's 2 new strains that I'm familiar with. The one is in England, started in the south of London, actually beyond London in Kent. And it seems to be 70% more contagious, but not more lethal. So while contagious we don't like, it means it spreads quicker. It's more of an issue in controlling this pandemic, but it's not more lethal. Answer, do your present natural antibodies protect against it? Yes. Do the present vaccines protect against it? Yes. There's another strain which is in South Africa. They believe it is not the same strain as in fact, they know now. It's not the same strain as the English one. It actually originated in Nigeria, came down to South Africa, picked up in South Africa, about the same, 70% more contagious. What happens with coronaviruses is they mutate all the time. In fact, the rate of mutation of this particular coronavirus, this COVID virus, is very slow relative to what's usual with coronaviruses. Usually coronaviruses mutate much quicker. If they mutate and they change in a way where they are able to evade, so to speak, your antibodies, then a new vaccine would need to be produced. The vaccine right now does cover these new strains. Being that it's this mRNA, if you use the Moderna and the Pfizer, it's very quick and easy for them to add new mutations into the vaccine. But obviously you would need to get revaccinated to protect against the new strain. So that's something we need to be out on the lookout for, because this can change continuously and can cause problems. So far we're seeing that, thank God, the mutations are really slow and therefore less of an issue. Any questions? Thank you so much.